split the session up into upper limb, lower limb, and a little bit on trauma. We'll have some SBA questions in each section with a vignette. And I think vignettes are a good way to learn. It's mainly how the questions are asked and the learning outcomes you'll see there. Now, I think SBA questions are actually very important. In my medical school, it's all we were tested on actually is single best answer questions. And you go on to do it into your postgraduate exams as well, like MRCS and MRCP. A lot of them have SBA style questions, okay? So trauma orthopedics, a lot of it's anatomy as well, actually, that you get tested on. So we'll build in some anatomy knowledge as we go along, and hopefully this will be useful. So I'm going to start with the upper limb. So what I'm going to ask you to do is if you want to speak or post into the chat function the answers, I think that's probably an easier way, and we can see who the majority of people are thinking with the answers to the questions. Okay, so we'll start. A 34-year-old man is involved in a road traffic accident when his motorbike collided with a car. He's assessed in the emergency department and found to have a painful right arm and inability to extend his wrist and his fingers on that side. He also had a painful left wrist. An X-ray shows a complete displaced fracture of the midshaft of his right humerus. He's found to have a head injury which is superficial. Okay, so I'll give you another second to read the scenario. It'll also be present on the next slide, so you can look at it again whilst you're looking at the questions. Okay, so here are the questions. Which nerve's been damaged? And where does this nerve run in the upper arm? I'll give you a couple moments to think about that. The scenario is on the right. If you want to post in the chat function your answers, or you want to stick up your hand and give an answer, then please do. Yeah, start posting once you're ready.
I'm also happy to run a poll if you'd like. So everyone...
Oh yeah, perfect. Yeah.
Yeah. So let's do the first question first. So which nerve has been damaged?
Sure.
Mm-hmm.
See, good. Okay. So the majority of you, okay, have gone for the radial nerve. We'll go through it in a second on the next slide. So if Pia, if you could kindly do a poll for the next one.
Sure.
Thank you very much. Okay, fine. So we've got a bit more of a split there, with some people saying A, some people saying C, but the majority going for B. Okay, that's great. Thank you. We'll move on to the explanations of this one. So the majority of the right with the first one, which is the radial nerve. Now, the radial nerve comes from the roots of C5 to T1 of the brachial plexus and is part of the posterior cord as well. Now, it runs posterior to the humerus in the radial groove, which is why it is at risk when you fracture the midshaft of your humerus. Now, a lot of people think that nerves are fairly, they're not very vulnerable when you have a fracture, and they're usually quite good at not getting broken and damaged. But actually, because it does run posterior to it, and it's at risk of getting damaged. Okay, so it also supplies it runs near the radial groove, so it also supplies the extensors in the forearm. Okay, so that's why you get a wrist drop classically when you have a radial nerve palsy or damage in this instance, and it also supplies the extensors in the carpometacarpal joint as well, so that's why you get a loss of the finger extension too. Okay, so well done to the majority of you got the radial nerve. Less of you got where it runs on the humerus. Anatomy is really important in orthopedics and in surgery in general, so it's important to know these. Okay, so we'll move on to the next questions. Okay, so on secondary survey, you find the patient is tender to deep palpation on the dorsal aspect of the left wrist over the area between extensor pollicis longus and abductor pollicis longus / extensor pollicis brevis on those tendons. Now, if you're not quite sure on the anatomy of them, then we will, I've got a picture there for you, which makes it slightly easier. So again, we've got the question, which bone is likely to have been fractured in this? So they've got pain on deep palpation in the area that's marked on that hand. Okay. Yeah, would you mind doing a poll for me? Good. So the majority have gone for the scaphoid. Excellent. And then, so what is the blood supply to this bone? So the majority of you have put scaphoid. So what is the blood supply to the scaphoid? Distal to proximal. Okay, that's great. Thanks very much for that, Pierre. Okay. So does anybody want to speak and try and explain to me why that's important? Why is it important that the blood supply is distal to proximal? Peter, I can't see if anyone's put their hand up, so would you mind just asking someone to speak if they have?
We've got one suggestion, AVN.
Okay, yeah, that's in the chat. Yeah, okay, good. So avascular necrosis. Okay. We'll move on to the answers. Yeah, which bone's likely to have been fractured? So again, anatomy is really important. Identifying injuries based on anatomy is really important in orthopedics. So this, we're talking about the area, which I will use as a visual. We're talking about this area in here. I appreciate it's on the opposite hand to the one that I described on the previous slide, but it was just a good picture to illustrate it. So this area is called the anatomical snuff box, and it's often palpation over this region that causes pain is common in patients that have suffered a scaphoid fracture. Okay, now it's often in people who fall onto an outstretched hand, whether that might be flexed or extended. Actually, you can get an injury in both, but it's important not to miss, because if the scaphoid is fractured and it's got an interesting blood supply, so it runs from distal to proximal, it's a branch of the radial artery. If you damage that, then the proximal end, which is less vascularized, can have avascular necrosis, which is essentially death of the bone. And that bone will never recover, and patients are likely to get further complications. They'll get arthritis, it's just very nasty if it's missed. So it's really important that you're aware of the anatomy of that, of the carpal bones, and where you might palpate for somebody to have this injury. Good, but it's good. I'm glad that most of you have got that right and identified that. Okay, so we have a couple more questions. So a boy falls on an outstretched hand. His X-ray shows a Dinner-Fork deformity with a distal fragment angulated dorsally. Which type of eponymous fracture is this? Okay, so good, the majority of you gone for a Colles fracture. Good. Okay, and so the second question is, a 23-year-old rugby player falls directly onto his shoulder. There's pain and swelling of the shoulder joint. The clavicle is prominent and there appears to be a step deformity. What is the most likely diagnosis? Okay, good, so the majority of you gone for an ACJ dislocation. And a couple of you went for glenohumeral dislocation. Okay, fine. We'll move on to a bit about the explanation of them. It's good. Most of you are getting the majority of these right, which is really encouraging. Good. So the first question was, is X-ray showed a Dinner-Fork deformity with distal fragment angled dorsally. Okay, so these eponymous names for fractures are very difficult, actually. And I think it's a bit archaic, the way that they're labelled. It's labelled after someone. It doesn't describe the actual fracture or the deformity, which it would probably be a bit better in today's day and age. And often most people will just describe something as a distal radius fracture, which is angulated dorsally. But for your exams, it is important to know the common eponymous names for fractures. Okay, so as the diagram shows, you've got a distal radius fracture, so we always describe fractures in relation to the distal fragment. Okay, so in this instance, in the Colles fracture, which is the most common fracture actually of the radius, and happens when you fall with your hand outstretched onto your palm with your hand extended, with your wrist extended to save yourself. And you get this Dinner-Fork deformity which forms in the wrist. Okay. Does anybody want to try in the chat to give an idea or a description of any of those other 3 fractures if they think they know?
A volar displacement.
Yep.
Yeah, again, Smith's distal radius fracture, distal fragment angled volarly.
Yep, perfect, that's good. So that's really good, that's correct. So it's essentially the opposite way around, and the injury happens the opposite way around as well. So if you think that you fall on an outstretched hand with your wrist extended, the opposite happens if you flex your wrist, and that gives you a Smith fracture. Okay, so the other 2 are a bit more complicated. So, well, they're not complicated, they're just a bit less common. So Bennett's fracture is where you get a fracture of the proximal phalanx of the thumb, but that is intra-articular. So you can get a fracture of that usually from impact injuries. And then a Barton's fracture, which is a bit more complicated again, and you probably won't need to know, but it's a differential, is a fracture of the distal radius, and you get dislocation of the radiocarpal joint. So your bones here are no longer aligned. I'll draw a quick. So the bones here in this diagram, this piece of the radius will still be aligned with the scaphoid and the lunate here, and it would be aligned in here as well. That's not true lateral, that's just a diagram. But in a Barton's fracture, you'd actually get dislocation of that joint as well as the distal radius fracture. Okay. Now on to the next question, which we discussed. The rugby player falls directly onto his shoulder. It's a very common injury. I've actually done it myself. It's very painful and takes ages to recover from. And you basically break or you rupture some of the ligaments that hold the ACJ, the acromioclavicular joint, together. So that could be the conoid or the trapezoid ligaments, or the acromioclavicular ligament itself. And there's various grades of injury, from 1 to 5, depending on how severe it is and where the clavicle ends up. So this would be quite a severe injury. You can see here that he has got a completely off-ended clavicle and it's tenting the skin. So this would be a high-grade acromioclavicular joint dislocation, and that will cause you serious trouble actually in trying to recover and in your daily activities. So that would probably need surgical fixation. The first grade 1 to 3, which you don't need to worry about really the grading until you want to study orthopedics, but they are managed conservative usually because there's not actually that much separation between the clavicle and the acromion itself. But this injury here would need fixation. So supraspinatus tear. Does anybody know what which movement of the arm would be difficult if you have a supraspinatus tear?
Someone's quick on the draw.
Yeah, I can see.
Abduction.
You see Sal's nose, his or her orthopedics. Yeah, so abduction, good. So the supraspinatus does about the first 10 to 15 degrees of abduction of the shoulder. And then your deltoid takes over. So if you get a tear of your supraspinatus muscle, you'll find initiating abduction quite difficult. A glenohumeral joint dislocation. So that will present itself. Usually a patient is unable to use their shoulder completely. They'll come in, usually either they've got a condition, which means they're hypermobile, which means they dislocate quite regularly and they're used to it, or they've had some sort of trauma to that joint, and you'll feel a step deformity in the shoulder, in front anteriorly probably. And a humerus fracture would present with pain lower down, so that's how you can exclude that differential. Okay, so has anybody got any questions there after the first questions on the upper limb?
Nothing at the moment, but I'll keep an eye on the chat.
Yeah, that's fine. I've got the chat up as our business.
Oh, right.
Okay, fine. So we'll carry on to the next section and then we can take a little break afterwards if people want to. Okay, so we'll move on to a bit about the lower limb now. So here's another scenario. So a 60-year-old man is involved in a car crash when a lorry loses its load of oil all over the road. His right leg is laying shortened and externally rotated. He's complaining of pain in his right hip. His left lower leg is burnt circumferentially and he's reporting increasing pain in his calf muscle. He's complaining of some numbness and tingling on the dorsum of his left foot, but his pulses are present. Just give you 10 seconds to read that again and then we'll move on to the next slide. Okay, so we've got two questions here again, and the scenario or the vignette's just on the right-hand side here if you need it. Okay, so question one, what is the most likely diagnosis leading to symptoms of paresthesia and pain in the left lower leg? Okay, so one person's gone for DVT, most people have gone for compartment syndrome, and two people went for cellulitis. Okay, so given his presentation here, which is that he's got paresthesia in the dorsal first web space of his foot, what nerve do we think is compromised? Sorry, that's actually a typo. It should say dorsum of his foot, not the dorsal first web space. So go for dorsum of the whole dorsum of the foot, which it says in the scenario. I'll explain why in a moment. Okay, so 12 of you have gone for common perineal. One person's gone for femoral, and 3 people have gone for sural nerve. Okay. So we'll go for the first question to begin with. So yeah, what's the most likely diagnosis leading to symptoms of paresthesia and pain in the left lower leg? This patient has got what seems to be worsening pain that's quite severe. He's got paresthesia in the left lower leg, which would often indicate that there's some sort of nerve compromise, which happens in compartment syndrome. Now, compartment syndrome is usually a clinical diagnosis. It can be diagnosed using compartment pressures, but it's less commonly done actually, and it requires quite a lot of skill to be able to insert a pressure monitor into someone's compartment. So clinical diagnosis. Swelling of the muscle compartments due to pressure rise, which results in muscle death. Okay, so often patients are seen with an increasing analgesia requirement and pain that is just out of proportion to their injury, or the pain that just cannot be controlled. So can anybody give me an extra mark, if you can post in the chat, and say what is the treatment for compartment syndrome? Fasciotomy. So one person's put pain relief. Now initially, so it's a good answer, and definitely someone needs analgesia with compartment syndrome. And the way that you actually will be able to work out whether someone's got compartment syndrome is if you give them pain relief and nothing happens, and actually if the pain gets worse or they've got an increasing morphine requirement, often it's morphine because it's the strongest painkiller we give them, then it's a sign that they might well have compartment syndrome. And you can test it by passively stretching their compartments as well. So you can flex or extend the toes based on which compartment has the compartment syndrome. You'll be able to work out whether it's likely that they've got compartment syndrome. That's really important we don't miss it, because it is essentially muscle death. So it needs an urgent fasciotomy. Okay. Now, sorry for my and the 5 Ps there for the neurovascular assessment. So if they've got pain, check if they've got pulses, check if there's pallor, check if there's paresthesia, and check if they've got paralysis of the muscles in the compartments. Okay, and that is to assess both nerve injury and vascular compromise as well. Okay, so we'll move on to the next question. My apologies for writing the wrong part of the question on the previous page. It was meant to be this question, which is on the second page. So what nerve is compromised causing paresthesia in the dorsum of the left foot? So the answer is the common perineal nerve. Now the common perineal nerve, then it can now comment into the chat and give me an answer as to which nerves does it divide into. Yeah, so the superficial and the deep. So the superficial perineal nerve supplies the lateral compartment of the lower leg. So that's your peroneus longus, peroneus brevis. And your deep perineal nerve supplies the anterior compartment, so EHL, EDL, which is its muscular motor supply. Now, the deep perineal nerve supplies the first web space, which is indicated here on your diagram in orange. Okay, and the superficial perineal, which they also can call fibula, on here, supplies the dorsum of the foot. Okay, so if you get nerve paresthesia or complete loss of sensation over the whole dorsum of the foot, it's likely that it's the common perineal nerve that has been damaged, or that it is the compartment syndrome is fairly high up in the leg, so it might well be in more than one compartment. Okay, so it comes around the head of the fibula of the common perineal nerve. If you just had loss of sensation in the first web space, and it's likely to be anterior compartment. Okay, so it's very useful to know your anatomy again in orthopedics to be able to work out which compartment might be affected in compartment syndrome. Now, someone has posted saying, would you also have weakness? Now, you wouldn't necessarily have weakness. You can't definitely say someone have weakness, but they could well do. If the nerve was very, very compressed inside a compartment that was swelling up, and you could well have some muscle weakness as well. Okay, so inability to wiggle their toes, for example. Okay, so extending the toes would be anterior compartment, and then flexing it would be part of your posterior, deep posterior compartment. Okay, and someone's asked which clinician would do the fasciotomy. So it would likely be orthopedics that do the fasciotomy. That would be who does it definitely in a district general hospital. In St George's, the plastic surgeons will often do some of the fasciotomies, as there could well be some nerve compromise, and they're the specialists at repairing nerve, and they also take on quite a lot of complex soft tissue debridement as well. So most often it will be the orthopedics, and it will be a registrar or a consultant. There'll be no SHOs that are doing that. And it would be plastics, potentially, that might do that.
Thanks for watching. Don't forget to like and subscribe. If you're watching this on YouTube, head to our website to watch the next part. If you're already there, just mark this part as complete.